Good evening, everyone. My name is Simiran Choudhary, and it's my pleasure to welcome you all on behalf of Voice of Healthcare to today's panel discussion Right Diagnosis, Right Treatment Improving Patient Safety Globally, organized by Voice of Healthcare and supported by SUT Pattom Hospital in celebration of World Patient Safety Day 2024. This year's theme is Get It Right, Make It Safe. Focuses on critical importance of accurate and timely diagnosis in ensuring patient safety. In healthcare, diagnostic errors, whether missed, delayed, or incorrect, are a major cause of preventable patient harm worldwide. Today, we aim to shed light on how collaboration between patients, healthcare professionals, and makers can improve diagnostic accuracy and ultimately patient outcomes. For this amazing panel discussion, we have an esteemed panel of experts who will provide us valuable insights on pressing issues. So I would like to welcome Dr. Rajasekharan Nair, HOD and Senior Consultant OBG SUT Pattam Hospital. Welcome to our show, Dr. Nair.
Thank you. Thank you.
Then we have Dr. Roshin P, Neonatologist SUT Pattam Hospital, but unfortunately because of some emergency, he's not able to join us for today's panel discussion, but he was supposed to be part of this. That's fine. So moving on to Dr. Unnikrishnan M, HOD and Senior Consultant, Vascular and Endovascular Surgery, SUT Pattam Hospital. Welcome to our show, Dr. Unnikrishnan.
Thank you.
Now, I would like to welcome Dr. Ammu Sreeparvathi, Consultant ENT and Laryngology, SUT Pattam Hospital. Welcome to our show, Dr. Ammu.
Thank you.
Thank you so much to all the panelists for joining in for this amazing panel discussion on such an important day, which is World Patient Safety Day. So, without any delay, I would like to begin this discussion and I would like to ask my first question to Dr. Nair. Dr. Nair, on World Patient Safety Day, the focus is on ensuring accuracy in diagnosis to improve patient outcomes. In obstetrics, how do diagnostics error impact maternal health and what specific strategies can be implemented to improve the safety and accuracy of maternal and fetal diagnosis?
Thank you, Simran, for that particular question. As you have rightly pointed out, increasing accuracy in diagnosis will definitely enhance patient safety, and there is very little doubt about that. It's also true that diagnostic errors can have substantial impact on maternal health. However, in day-to-day practice, we have to depend on investigations frequently to make a correct diagnosis. When it comes to OB-GYN practice, I can point out a simple diagnostic modality which has radically improved our understanding about the mother and fetus, that is the ultrasound. Before 1980s, first trimester complications such as ectopic gestation, vesicular mole, etc. were diagnosed solely by clinical science. But now we can confidently diagnose these conditions very early in pregnancy, and appropriate treatments have drastically brought down maternal morbidity as well as mortality. It's also true that we are able to follow up the anatomy as well as the well-being of the intrauterine fetus right from the first trimester to the last trimester and act accordingly. And these strategies are heavily dependent on the accuracy of these investigations. So ultrasound has become the third eye for the obstetrician. Similarly, a large number of biochemical investigations starting from pregnancy test to CA identify and the genomic studies on the extreme has helped the practicing obstetrician and gynecologist to bring down maternal as well as the perinatal morbidity and mortality to the present status. Finally, to answer your question in one sentence, I should say that as the quality and reliability of investigations increase, we are witnessing a parallel increase in safety to patients. Thank you.
Thank you, Dr. Nair, for explaining that to us on on OBG and how it affects the mother and the fetus as well. Moving on to Dr. Unnikrishnan. Dr. Unnikrishnan, can you please explain us in terms of vascular and endovascular surgery, how do diagnostics delays or error influence treatment outcomes, and can you share how timely diagnosis can drastically change a patient's recovery?
Yeah, thank you for that question, Simiran. In fact, In vascular surgery, it's most important to have an appropriate and a quick questions or the symptoms that the patient comes to you. That's paramount for any decision of any following investigations. Number one. Number two, a quick again clinical examination of the cardiovascular system and all the pulses, including the neck, limbs, arms. So all that will tell us the physical signs and abdomen also. If there's pain in the abdomen for some time, it may be a backache because aorta is situated near the spine. So history and physical examination are nearly diagnostic. What we require is confirmation. So exactly like my colleague and senior person, a medical superintendent told us, ultrasound and duplex. Ultrasound tells us the solidarity and the situation per se, and Doppler is to identify the blood flowing inside the artery or vein. So that tells us the system concerned, which is diseased, which is troubling the patient. To confirm further and to make sure you are getting the diagnosis and status of the patient correctly, then we have the angiogram, and most importantly vascular surgery we use the CT angiogram, because the details are given, including all the entire vessels, in particular the vessel which is supplying the organ which is gone to us with with some kind of disease or symptoms. So it's a altogether we will combine and take a decision what we call patient centric, depending upon his disability, this depending upon this seriousness of what we find. And then we have three options, like we can help him with medications. Say for example, if anybody comes with deep vein thrombosis, immediate surgery is not required. We have to identify, of course, with all this and start him on unfractionated heparin. Then we have low molecular weight heparin or anticoagulants, which are different types. That's number one. Number two, in situations like acute aortic syndrome, to differentiate between a threatened aneurysm, threatened rupture, which is likely an aneurysm, or an aortic dissection, the CT angiogram is mandatory. It really saves the life of the patient, tells us the management options. Then again, if you look at the stroke, when you are talking about stroke, it's the second commonest cause for death and morbidity. It produces catastrophic morbidity because the patient is bedridden, one arm and leg is paralyzed. There are problems with basic features like passing urine, motion, and so they are not able to speak sometimes. So there, what we call the pilot symptoms, like for example, a little visual blockade in one eye, or if they have a transient, meaning few minutes to an hour, definitely less than one day, if they have a paralysis, it may improve, but that's a pilot symptom which has to be worked up and investigated. And the most of the disease processes can be identified with those. Rarely we use IVS specific terms, a DSA, or even MRA or MRI, but that's not very commonly used. It's only supplementary. So it's very important that we utilize all the features, all the diagnostic, uh, the devices and the latest technology, and then make the decision patient centric depending upon the seriousness and his disability, and try medical treatment, keyhole surgery, that's endovascular surgery, or open surgery, which is gold standard.
Thank you, Dr. Unnikrishnan, for explaining that to us. But I have one follow-up question on that. I have seen, or in my experience, I visited few doctors, and they were little hesitant for the MRI. I just want to know, that is one of the part of the diagnosis. So why this one little hesitancy for sending a patient for MRI? I believe this one thing, they always kept saying, ki, okay, if you do that, that will get documented and there is no requirement of that. But don't you think that MRI or any kind of other diagnosing machine would actually simplify what exactly is happening to the patient?
Yeah, actually, there is no investigation which does not give any value. There is value to each investigations, but the problem with MRI takes about 45 minutes to 1 hour. If the
Yeah.
patient is not in stable condition, unconscious, and so we don't have to depend upon 1 hour MRI. This what is known as a golden time of say stroke prevention. Usually, it used to be about 2.5 hours. Now it is 3.5 and 4 hours. If the patient comes with a stroke in within that window period of 4 hours, we can do in 5 minutes a non-contrast CT scan and rule out hemorrhage in the brain and give thrombolysis in the CT console itself. So that is the difference between going for MRI and this thing. And MRI is mostly used for brain, spinal cord, and soft tissues. And when you are looking at blood vessels, the diagnosis, I think there's nothing which cannot be told by the CT angiogram. We can always supplement with DSA, digital, that is the cath lab procedure. We can inject the contrast picture directly into the any one of the vessels in the veins or in the arteries and study the obstruction, bulging, or whatever the disease is involved, maybe AV malformation. So that's why MRI we are not hesitant in using. Sometimes we would like to know not only the blood flow and the blood vessels, but the surrounding soft tissues. There we use MR, but MR is not a basically a not in the package. Very rarely, maybe 10%. I will not ask. In the last 5 years, I have not asked for a single MRI in my practice.
Thank you for answering that. Moving on to my next question, Dr. Ammu. Dr. Ammu, you are into ENT, right? So I would like to know your views on how do you address the challenges in diagnosing subtle or complex ENT conditions, and what are the most common diagnostic pitfalls that can affect patient safety?
Okay, thank you, Simran, for that question. So, coming to the answer, see, basically, I believe that you should take a proper history of the patient. That is the first and the foremost thing. So, take a proper history, and the patient should be confident in you to tell you everything regarding his history, medical history, whatever medicines he was taking previously, whether he had seen anybody. All the history is very much important. Based on the history, based on the rapport you build with the patient only, you can build a differential diagnosis. Okay. Now, based on your history, you can go on to the clinical examination. Coming to the clinical examination part, you check the patient as a whole. Just because a patient will come to you with a nasal complaint doesn't mean you can omit the ear or the throat part. You ENT is connected, so you check the patient as a whole, the whole ear, nose, throat, and then as a whole we should check the patient, and then only you go in for an investigation. So where the pitfall happens is before doing a proper examination or before doing a proper evaluation, when you go in for an investigation, which might not be needed, it will be like you're treating the results and not the condition of the patient. So I believe that it is always better to take a proper history, to get a elicit a proper history from the patient, get a proper examination done, and then as a diagnostic tool in ENT, we can use endoscopies, we can do microscopies where we get a very clear, very accurate view of the nasal part, eardrum, etc., with which you can give a clear-cut diagnosis to the patient. So basically, the rapport which you build with the patient will bring out a beautiful history and a proper diagnosis for the patient rather than sending for multiple investigation. Like earlier, you asked why people are hesitant to send for an MRI. So when you send the patient for an MRI, you will get a different diagnosis, which the patient didn't come for. The patient might have come for something else, but when you do give the patient an investigation to do, they'll come back with a different result. And treating that result won't be apt for that patient. So the patient will be saying like, I came with this thing, but you're treating this, so it might not be proper. So always a proper history, a proper examination. Based on your examination, if needed, you go in for an investigation. Thank you, Simran. I hope I answered your
I just,
question.
I just want to add to what Ammu has correctly said. See, Simran, you must have heard of William Osler, the great doctor, Englishman, who is still regarded one of the finest ever. He says the patient is telling the diagnosis.
Yeah.
You listen to the
Yes, sir.
history. That's what he says. Listen to the patient. He or she is telling you the diagnosis, because their symptoms and the way of telling their suffering, it gives the clue, most important clue, not a picture or CT or MR.
You said it right, Dr. Unnikrishnan, and Dr. Ammu, you explained my or answered my question very well in a very layman language, so that out there, people, listeners out there who ever went to doctors or anything, they can relate to this. So thank you for explaining that to us.
Thank you
Moving
so much.
on, my next question to Dr. Rajasekharan. So, this year's theme is Get It Right and Make It Safe. So, how do diagnostics delay in gynecological condition affect patient safety? And exactly what are the key challenges in early detection that healthcare system should address to improve outcomes for women? Because why, particularly women in this case, normally they neglect what is going on with them, their health. Most importantly, they take care of their family very well. They address, or they will be on their toes to help out their family, but when it comes to their health, they neglect it. So how
Okay.
can that help in improving the outcomes?
That's really a very pertinent question. Whenever we hear the term delay, I think you can expect an adverse outcome in almost all cases. And diagnostic as well as treatment delays can be usually clubbed under the term in hospital delays, or otherwise called the third delay, as put forward by two gentlemen doctors, Dr. Thaddeus and Main, in 1960s. This is particularly applicable to the maternity care, but it holds good in other specialties also. We were under the impression that the first delay, that is, delay in seeking medical care due to ignorance or social beliefs and customs, etc., and the second delay due to poor access because of geographical terrain, lack of healthcare facilities, etc., nearby. So that is the second delay. But the main reason can be the third delay, which is called the lethal delay. That is, once the patient reaches a facility, the delay which occurs subsequently can be very 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 difficult situation. Most of the hospitals, this is one of the um, problems which has been recently recognized, and nearly one third of the safety issues occur with this type of patient, that is so-called in-hospital delay. In obstetric practice, for example, in a case of preeclampsia or a suspected case of placenta previa, this delay could be a deadly mistake on the part of the healthcare team. So there should be standardized protocols, care bundles, etc., and they should be strictly observed, adhered to, in order to minimize this impact of such in-hospital delays. So we should also realize that the human element is not the only thing responsible for the delay. The system factors are equally important, such as poor resource allocation, positive healthcare personnel. All those things can be a critical. So I think I will allocate 50-50 for these, the system factor versus the human factor. So to avoid delay in diagnosis, all the three delays must be addressed to bring in some visible changes in the health system. But they will continue to offer real challenges in any country, even in economically advanced countries. They find it as a very difficult issue, leave alone developing countries as ours. So thank you.
You said it right, Dr. Nair, that these three kind of delays. One is neglecting, and then is access to proper health care, and then finances and every other thing. So normally, yes, this puts up in a delay in diagnosis and makes the case adverse and everything. But then now, how things are improving in our developing countries, more and more people are getting access to healthcare. There are other support system, patient advocacy groups. They are kind of helping patients, or people, or to get the voice there to the system, that this particular area actually needs that healthcare funds or support from government or things like that. And with doctors like you, hospitals like SUT Pattom, and is making that possible to reach, to get that healthcare access to each and every person out there. So, and you answered that very well. Thank you for that.
Thank you.
Dr. Unnikrishnan, accurate diagnosis is a cornerstone of patient safety, especially in complex vascular cases. What imaging technologies or diagnostics tools, and that these tools are very important and crucial for ensuring accuracy in your specialty, how can they be optimized to enhance patient safety? In case, let's say, patient is coming when he's in a very difficult condition, or like we said, some adverse cases, because negligence is always there. So how can this be optimized for patient safety?
Yeah, thank you. That is in theory, but it is difficult to achieve, but it is possible. In fact, from what I described, as well as Dr. Ammu mentioned, uh, comprising of the history with physical examination, we can have a reasonable diagnosis or a differential diagnosis, go for a very focused investigation. Now that habit is slowly going, because many doctors look at CT and MR, then only correlate. I think it's a retrospective step. I feel it should be focused to the patient's problem and choose. It may be sometimes a Doppler, but Doppler is like, for example, it is non-invasive. It can be done maybe 2 or 3 times. It can be done by as many observers or radiologists. But the CT scan and MR, if at all, when you use, like MR can be used in aortic dissection. People are using it more. But then CT scan also, if you are confident, if you are experienced in treating, you can use a CT scan. Maybe you can use for, because MR, as I said, half an hour, 1 hour, they have to lie down in that console. It is pretty difficult. So you have to choose the investigation exactly according to patient's history and physical examination, and focus it for the um, the system involved. And of course, we should look at the entire patient, do the basic investigations. And now that, say, for example, in vascular and endovascular, 75% of all mortalities occur because of cardiac problem. So we should proactively ask them whether they have any difficulty in breathing, chest pain history, admission in because of a heart attack. All that has to be questioned and added, so that you can look at only medical management maybe for an 85-year-old man, or an aggressive open surgery for a 50-year-old, 60-year-old, or in the via media keyhole surgery. That's also very effective, and it is complementary. Not only now it's complementary, it is becoming the first choice in many vascular and endovascular therapies.
Thank you for
Thank
answering that, Dr. Unnikrishnan. Moving on to my next question, Dr. Ammu. Dr. Ammu, we are seeing innovations, advancements in technologies and everything. So, what innovations or technological advancements are currently enhancing the diagnostic precisions in ENT? And how can these be further integrated into healthcare system to ensure better and safer patient outcomes?
Thank you for that question, Simran. So earlier, when I used to learn, when long back and all, we used to have bullseye lamp, we used to have headlights, we used to have laryngeal mirrors, nasopharyngeal mirrors to examine the ear, nose, and throat. And even the difficult areas used to be examined with these. But now, as time has progressed, we are using endoscopes. That is, we have rigid endoscope for doing a nasal endoscopy. We have microscope to see the ears. We have a flexible endoscope to see the throat. You get a very accurate, you get a very precise view of all these structures. And based on that, all your investigations can, come down because you're having a direct view of whatever you want to see. You seeing the eardrum very clearly with an otoscope means earlier we used to see with just a torchlight. Compared to that, this is improved so much. You see the small ossicles, everything can be seen. And this means ENT has come so far ahead, and we have got audiograms, we have got tympanometry, we've got a lot of new stuff coming in ENT, and even for doing the surgical part. This is what it's for diagnostic purpose. What I've told, even for surgical part, earlier it was always a cold steel surgery which we used to do, like with the knife and instruments. But now as time has passed, we are using debriders, we are using coblators, latest. We are using lasers. So it has advanced a lot. And with all the investigation tools, like all the diagnostic tools, with all the endoscopies and all, the main advantage is that you can record all these findings. Earlier, you used to see with an otoscope or you used to examine with a mirror and then you used to write down your findings. Now, what has happened is with the camera attached to the endoscope, you can record all the findings and all the findings can be given as a report to the patient as well as retained in the hospital. Now, in future, when there is an AI or something setup is happening in a hospital, you can feed all these data into that, and you can create a good database, and in future it might help a lot. That is how you can improve the patient's approach towards all these things. I hope I answered your question.
Yes, yes, you answered my question, but I have another question on that. You have let us know about the new technologies which are currently in use, but I want to know more about what else are we looking forward to? What else more technologies can be seen near future that can help us in diagnosing process?
See, the latest that has come into ENT is definitely artificial intelligence. That is there. But the problem is in AI, what happens is if I feed data of 1,000 patients with a change in voice, for example, a patient with a vocal cord nodule, they will have a particular kind of voice. So I take up the data of 1,000 patients coming to my OP. When the data is more, the AI will give a better result. So if I feed this data into the AI, the next time a patient walks in with a similar kind of voice, the AI will say, okay, so probably this patient will be having a vocal cord nodule. But then again, you need to have that much bulk of data. But the main problem with this is you need a physician, you need somebody physically to put in the scope into the throat or into the nose or into the ear and see, and then okay, you can 100% say okay, this is a nodule. AI and all is just coming up, so it is coming up, it will definitely catch up later. Going on to robotics and all, everything will catch up. But at present, even though AI is there, even though we are feeding all the data, to see manually and confirm the diagnosis and then start a treatment, definitely manpower is needed. So I would strongly say, though AI is coming, it will take away most of our jobs. Still, whatever we know, that much I don't think AI can appreciate. And always it is the based on whatever we feed into them. So for a particular disease, maybe some few things we'll be seeing and few things we'll be feeding into the data. But then at a later stage, what will happen is they will only check for these particular things. They will not think out of the box. And one more issue, what I feel would happen is like, the more you depend on all these things, the more expertise the junior ENT people who are coming out will have is very less. See, because if
Yes.
you ask a patient to do, if you ask an ENT person to do an antrum puncture or do a procedure which was done long back, which was a very handy procedure, they'll not do because they have not seen because of the invention of endoscopes and all. So in that way, I strongly suggest AI is coming up, and I feel that we will be going into artificial intelligence and all. But still, but still, uh, I think manpower is much needed.
You said it right, Dr. Ammu, that manual intervention, observation, or kind of supervision would be still required there to ensure that AI is able to capture the accurate data, or is a place where that can be the data can be collected, right? And the expertise which doctors have with those who are working into field with patients directly without such AI tools, the kind of experience and expertise they have, uh, up coming up generation might not have that. And you
Yes.
said one of the things in my previous question, that the right diagnosis also helps doctors to understand the history of the patient, how
Yes,
it is
very
come.
much, very much.
AI may not be able to listen or understand or go beyond that history. Okay, what all symptoms a patient is, suffering from, and everything. So that history, which a doctor understands and then uses their technologies and tools, diagnostics tools, helps them to understand more. But I think AI won't be that patient to understand,
Okay.
listen all those symptoms.
Yeah. The answers will
Actually,
be
there
very
is
fast.
Yeah, actually, there is no substitute for real intelligence, and medicine is not an exacting science. If you say statistics, it can be that 1 out of 100 which is coming. You can't say 90% will have this problem. So I think you cannot work with a computer drop down and treat a patient. Every patient is individual. I will tell you two examples. I got a call from Nagarkoil, next town in Tamil Nadu, that there is a deep vein thrombosis in the left leg in a 65-year-old man. Nothing else was told. Then I said, "Can't you manage there?" No, they said, "No, you please see. They are doctor's father. They want to come." When he came, I saw the report there. Radiologists have written up to common iliac vein. That is the formation of IVC near the umbilicus is involved. So I just gave the heparin unfractionated dose. Next day morning, I got a CT venogram and then found, to my horror, IVC clot is sitting there, large one. By 11 a.m., that is within 10 12 hours, we put an IVC filter, started him on management. Now he is doing well. That's number one. Number two, superintendent of police came to me. He came to SUT to treat his wife's some hernia, abdominal or something. Then casually he was telling his relative is in our hospital. He said, "I have increased pulsation in my belly." Then he said, "You get a CT scan." CT scan was done. It shows 5.3 centimeter abdominal aneurysm, and he has pain. He needs treatment. But he's been a smoker just 56 years. I said there's a chance for coronary artery disease in him. Got a coronary angiogram, 90% two-level blocks in the coronary artery. Had we done open or endovascular surgery, he would have had a myocardial infarction and died. So what I feel, the doctors will keep on building their real intelligence, not depend solely on artificial intelligence, because people wants to go on improving investigation, cost to the patient, affordability. That's a Western trend. I think we are in the middle path. We are more like Britishers. I think we should look at what patients require, do it patient-centric, not go, it's like a shooting in the dark into a wood. So, whatever, something will be hit with the bullet, but that should not be our pattern. It should be patient-centric, very focused to the patient, and we should look at the economic part of the affordability, economic part of patients. Everybody is not able to, at least hardly 50% can afford reasonable treatment. Rest 50%, that table 60 to 70 crores of Indians. Thank you, Simran, for that question.
Thank you, Dr. Unnikrishnan. You just gave us a right example on this topic, which we're talking on right diagnosis on right time. You just gave us that example. And the thing you got just by listening to this conversation or listening to the symptoms is a very good example, or your expertise, your experience, the kind of experience you have gained throughout your practice. That's why you could easily catch up. Okay, this might be the cause, this could happen, and that's how you got it diagnosed and treated. So I think we are discussing great examples here to justify this World Patient Safety Day and the theme for this year. So thank you for giving us that example. Moving
Thank you.
on. Thank you, sir.
Yeah.
Moving on to my next question, Dr. Nair. Dr. Nair, as we work to improve patient safety globally, how can healthcare providers better involve in pregnant women in diagnostic process, ensuring they understand the importance of early and accurate diagnosis for both their maternal health and their unborn child's health?
Personally, I believe that health of an individual is his or her own responsibility. It is not the responsibility of the state. Okay. The
Yes.
individuals must be encouraged to lead a healthy lifestyle, especially when it comes to reproductive health. And when a woman becomes pregnant, the couple should get expert advice either from the doctor or the midwife, depending on the situation. And in ideal settings, even a premarital counseling session would be a relevant proposition. And the diagnosis of any reproductive issue has two components: the clinical examination as well as the investigation. And ample discussion has been there regarding the importance of clinical examination, because in nearly 80% of OB/GYN situation, I think a simple clinical examination can be diagnostic. Only in about 20% we require some sort of investigation. For example, a ruptured ectopic, only by
Yes.
clinical examination I can diagnose, or even a ruptured uterus. But you look at the history and clinical examination, I think diagnosis is evident. We don't require ultrasound or MRI in such cases. And present day people are doing such things even with a clear-cut diagnosis for documentation purpose to avoid medical legal issues. So it's a form of defensive practice. So such things are not very relevant. Only 20% of cases need some sort of investigation. And the patient should be made to understand that it is not the investigations which are more important, it's a clinical examination. And they should subject themselves for a proper clinical examination. And circumventing this step and ordering for investigation without a clinical examination can have serious repercussions also, and in the treatment process itself as well as in the doctor-patient relationship. Because if the patient see that doctor is doing a thorough examination, that will itself be the beginning point of a good doctor-patient relation. And the patient must be told about the importance of undergoing, in case of pregnancy, we do serial ultrasound. That is an indicated situation. And she should be explained why we are doing this serial ultrasound, then why we are doing hemogram or a double marker, so that she will get optimal, cost-effective investigation at the proper time. Okay. Unnecessary investigations can be avoided. But at the same time, the availability and accessibility for imaging services, mostly USD, especially CT and MRI, as well as biochemical tests, must be ensured by the authorities. And these facts should be clearly explained to the patient and relatives so that their compliance can be ensured. Otherwise, the patient and the relatives will think that the doctor is getting some financial gains by ordering all these things. So clear explanation should be there in all these cases. Okay. So don't underestimate the physical examination, which is a necessary component in all these cases, and supplemented by selective investigation. That should be the attitude towards diagnosis of a particular situation. Thank you.
Thank you, Dr. Nair, for explaining that to us. I have a follow-up question on the same. Since we're talking about early diagnosis, accurate diagnosis for the pregnant woman and for their unborn child, I just want to know, please correct me if I'm wrong somewhere. I have heard few of the tests which can be done before pregnancy through the blood test of the mother and father, and then we can get diagnosed. Okay, what else could be the complications during the pregnancy or after the pregnancy when the child is born? What all diseases or things could happen to them. So how can this, which is something a new thing which came earlier, it wasn't there, I believe. So how
Yeah.
has this helped in better diagnosis or more awareness and prevention for any other diseases?
Yes. I think there are two issues. One, whether the current pregnancy, we can diagnose it early and we can prognosticate whether the outcome is good or not. That is one thing. Then before, that is prenatally, whether we would like to identify whether the woman is likely to develop an abnormal, to conceive a abnormal pregnancy. Of course, all these, the answer is quite clear. These tests are available. But only thing is that it is not a blanket investigation required for all cases. So again, the clinical examination, if there is a reasonably good suggestion that this patient is likely, for example, there are pregnancy problems in the first degree relatives, okay, or in the maternal or paternal side, etc. In such cases, you may order for these tests. Otherwise, there can be an element of commercial interest also, because these are one of the unhealthy things which happen in our country. That is, pregnancy, which was a physiological process. First, we have medicalized the pregnancy. Now we are commercializing the pregnancy. And that is why many of the hospitals are doing all these tests. Even before the patient is attending the hospital, they have to come with all these tests completed. That is not the ideal thing. But there are cases in which such tests are indicated. Okay. We are also having in our hospital the genomic studies. A high-risk patient, we order for a genomic test so that we can identify a few, ensuing problem in such a patient in the subsequent pregnancy, like that. But the use of these tests should be very selective, and the reasons explained to the patient. Thank you.
Thank you, Dr. Nair, for answering that. Moving on to Dr. Unnikrishnan. So, given that many vascular conditions are asymptomatic until they become severe, so how do you exactly ensure through diagnostic procedures are followed to detect them early and avoid any preventable harm to patients?
Yeah, that's a nice question because many of them, as you say, I mean, as you said, don't have the typical problem with the patient. Physical examination may not open up the findings, but there are, say, some questions like when somebody has been walking, say, 2, 3, 4 kilometers, and last 1 or 2 weeks he says he can only walk, say, 100 meters for no reason, nothing has changed. Then we should suspect definitely some blood supply, pure blood supply to the legs are reduced, and a physical examination bring out if there's any blocked artery. Worse come worse, one Doppler will tell us against the level of stenosis, the segment involved, and the approximate blood flow reduction in the limb. That's number one. Number two, a gentleman or a lady, mostly 9 out of 10 are ladies, are gents with abdominal aortic aneurysm. If they say they have been having backache for almost 1 month, they applied ointment, they took tablets, it's not coming. And if they are hypertensive and a smoker in a man, then I think we should do a clinical examination of the abdomen and prove that his aorta is normal, not aneurysmal and bulging and ballooning by an ultrasound. That we catch them at the appropriate threshold diameter for intervention, which is 5.5 in Europe and America. It can be some around 5 or slightly less than 5 to 5.5. That's time to kind of intervene. Number two. Third example is, again, these are lifestyle diseases where the cholesterol or fat particles are laid down at the branches of arteries supplying various organs like brain, kidneys, leg, intestines, all those, or in their branches. So what happens, say, for example, a 65-year-old man or woman, that for that matter, hypertensive, maybe mildly diabetes, says that he was feeling little giddy,
Hmm.
something like lightheaded, or even worse, his left one side hand and leg. He had some weakness while he was trying to drink coffee, or while he was eating or doing something, writing. There's a change that it will pass off, but the patient may not know it is called a transient ischemic attack, a sign of threatened stroke coming. It's a pilot symptom. So that if that is reported, the doctor should identify that he has to do an ultrasound of the brain arteries, look at the thickening, look at the cholesterol load, look at the way how much is shut down or shut narrowed, and the kind of blood which is going under high velocity. All that will call for a CT angiogram or an MR. Here it's not matter, but CT is much better, much confirming. MR over tells you the diagnosis. So that at that point of time, we can catch the patient before what she thinks is not a serious symptom. But for us, a transient ischemic attack is a serious symptom of something coming in weeks or months, especially if they are not on any treatment, if they continue smoke, or if they have diabetes not controlled with high blood pressure. So these are some of the examples. Although asymptomatic, what looks like a unrelated diagnosis, like backache, everybody says the spine. In Malayalam we call it vadam, Ayurveda, the treatment, and that is it cannot be related to any vascular. But aorta is almost to the left of the centrum in the lumbar area in the abdomen, and when it from 2 centimeter it becomes 5 or 6 centimeter, it gives a pumping effect on the spine, and they have backache. So backache not going away with conventional treatment, that calls for an ultrasound clinical examination and confirming that aorta is normal or it's aneurysmal. So we have a method of, so that is why I think, as Rajasekharan sir and Ammu said, clinical examination, prior to that history. Nowadays I have my OP I have about 5, 6 patients at the most. I spend half an hour to 40 minutes. I listen to them, and many people tell me the diagnosis. Already 3, 4 doctors would have seen treated. I said, I don't want to see anything. You are sitting in front of me. You tell me what's the problem. And just now, like I said, William Osler, listen to the patient. They are telling the diagnosis. So I think that William Osler's sentence I remember every day morning when I get up, because I have to listen. They are coming. This is like the coin, head and tail of a coin. All you have to do is just turn, listen, examine, and then you have the diagnosis, and you can appropriate investigation you can choose. And then of course it's always a team which works. I work with neurologist, I work cardiologist, I work oncosurgeon, I work with general surgeon. I sometimes even some whistling sound in the head, it will be the carotid aneurysm or something, it's pulsating. So all the and then voice is lost, recurrent palsy, it's a sign of arch of aneurysm. Arch of aneurysm will not be symptomatic because chest can take any number of, it's an open cavity, and a little bit of enlargement which happens slowly, it can take place without any symptoms, and 10% will have a acute rupture and patient will not even reach the hospital. So we have some specific symptoms, but then 20% of all come as emergency. Out of that, 50% of those 20% who come with the first symptom as complex stroke or a rupture aneurysm, they don't survive. Thank you.
Thank you, Dr. Unnikrishnan. You mentioned again a very important point about you listen to the patient first, and that's the first hand information you get, and then, if required, moving on to the diagnostic processes. So, my next question is to that only regarding that from Dr. Ammu, that patient communication is key to accurate diagnosis. We also talked in our previous question answers, especially in ENT, where symptoms can often be non-specific. It can vary from person to person what they're feeling and everything, and sometimes it becomes very difficult for patient to understand. They everyone have their own language to express, so sometimes it becomes very difficult to understand what exactly is happening with them, right? So how do you ensure that patient provides all necessary information, and what steps can be taken to enhance doctor patient communication to avoid any further diagnostics error?
So, thank you for the question, Simran. So, for this, we need to have a proper protocol for history. Like when I said history, it doesn't mean that you just take random history. For example, in SUT, we have an application where when the patient is talking, when the patient is giving their history, we have got each point to add, like present history, past history, medical history, all these things can be added. More than that, with each complaint, for example, if a patient is coming to you with a vertigo, you ask the patient a few questions. These are standard questions. So these things, what you ask is how long it is there, whether they have tinnitus, whether they have ear block sensation, whether the giddiness lasts for more than half an hour, whether how long it comes, how many days it lasted. So these kind of, if this is what happens for vertigo. So for headache, you should have another set of questions. So, like this, you should have a standard protocol question for each and everything. So, when you come out of ENT, when you come, when you learn, when you finish your house agency, when you are into your practice session, you know there are few particular questions which you need to ask the patient to elicit in history. So what happens is when you skip a few of them, you might tend to, miss out something. So to prevent that, I would strongly suggest always to follow a pattern or whatever pattern they have given in the system. In the system, they will have present history, past history, like that, and we can also add whatever we need into that, like for how long each disease is lasting. And more than that, like Unnikrishnan sir had earlier said, the number of patients coming to the OP, like you can't sit with one patient for like long time when you have a big OP waiting. So what you can do is you can set up a set of general questions for the patient. So when the patient is waiting, they can as well fill the questionnaire. So pertaining to the questionnaire, when the patient is walking in, we can always ask the patient, okay, so this is your complaint. So based on this, what all do you have? You can ask like that. So this will, minimize the waiting time of the patient. This will maximize the utilization of their time because they are telling everything. They'll remember the moment they walk into the OP, they'll remember, okay, so I have this problem. These are what you want to know. So I strongly feel that we need to have a standard protocol. We need to follow a standard pattern when you ask for a particular thing. When a doctor is asking the patient a particular question, the doctor will have few things in their mind. They'll think, okay, if this is this, this is that, and then based on that we can build a history. So I strongly feel for this to happen, we should also have a rapport with the patient. So I didn't mean like you need to see the patient push them up. No, you have to have the patient sit with you. You need to spend a quality time with them. You have to build a rapport with them and make sure that they are confident with you, so that then they will tell everything. And I always prefer talking directly to the patient. Sometimes the bystanders, they will not allow the patient to say. They will keep on saying, see, this is happening, this is happening. So I always tell, I want to hear from the patient's mouth what has happened. This is what I usually follow.
But yes, I think that's the one of the bestest way, and you mentioned a very right point of thing that rapport is very necessary, so that patient had that trust with a doctor and that relationship. That they can freely talk whatever they're feeling without any kind of hesitation or anything, and that helps in better diagnosis. So thank you for that. Moving on to Dr. Nair. Dr. Nair, we know considering the vital role of technology in patient safety. So, what advancements in diagnostic tools such as ultrasound, MRI, or AI, like we were talking about AI also, are enhancing diagnostic accuracy in obstetrics? And how can these innovations be more widely adopted in clinical practice in the coming days?
It is estimated that nearly 5 million errors, clinical errors, are happening in India annually. And many people think that errors, that is both diagnostic and treatment errors, can be reduced by sophisticated technologies. That is not always correct. Patient safety need not always increase with the technological advance in a linear manner. As far as obstetric practice is concerned, very little safety issues exist when it comes to ultrasound. But MRI, CT, etc., we don't use frequently, except in the gynecological patients where such considerations may not be there. And possibly some of the future technological innovations we can think of will be we can expect machines with more and more resolution so that the diagnostic accuracy can be increased. Then incorporating AI technologies to improve accuracy. Then slashing down the price of machines also. Maybe by Make in India projects, etc., we can bring down the costs so that it will be accessible to a larger number of women. That is another thing. Another area which we can popularize will be to design dedicated software which can be interfaced with the commonly used Android mobile phones, etc., so that the whole thing can be accessible to the common man at affordable cost. These are some of the innovations which you can think of in the long run. And I don't conceive any safety issues with any of the imaging modalities as far as the obstetric patients are concerned, unless it's a mistaken diagnosis or a misinterpretation of the findings. So the human factor should be carefully monitored because there is always a chance for human to err. So protocols and checklists must be there to avoid doing the uh, investigation on the wrong patient or the wrong site, and don't blame the machines or the technology in such cases. So due manual checks like verifying the identity of the patient, surgical site marking, etc. should not be omitted, whether you are doing a simple surgery or a sophisticated robotic procedure. And this is mandatory in all clinical settings to reduce the clinical errors. So along with the advances in technology, I think there should be an improvement in the human factor also. So thank you.
Thank you, Dr. Naya. You said it right that even having that sophisticated tools, technologies, or operationing tools, we still need to improve on human efforts, and this emphasizes on that human efforts or human involvement cannot be omitted in
Yes.
terms whatever, if even if we get best of the best technologies, best of the best AIs, but human efforts is always required in most of the medical cases, right? So thank you for that. Moving on to my next question to Dr. Unnikrishnan. With the theme Get It Right and Make It Safe, what emerging diagnostics trends or technologies in vascular medicine do you think hold most promise in reducing errors and improving the patient outcomes?
Yeah, see, in our practice of vascular surgery, it comprises open operations, keyhole surgery like endovascular surgery, and vascular medicine. About 20-25% or more patients require only risk factor control and their control of diabetes, hypertension, stop smoking, and take adequate diet, not too much or too less, drink a lot of water. Many of those, like peripheral arterial disease in circulatory problem in the legs, can be managed. Next, open surgery on this end of the spectrum will be needed, is mandated only something like 20%. So a wide segment, subset of patients can be managed with um, endovascular, what we call keyhole surgery. And we have in our radiology department, in our SUT, 128 slice CT, which is just only little different from 256, because although it is looking double, it's not much different. The quality identification, we can see small vessels, we can see where it begins, where it ends, what operation I have to do, whether I should do operation or go for keyhole. All that is analyzed and told us in the CT findings. And of course, we work as a team. I go to the console, look at the CT with available consultant, and our team is very good. So I, each time, even with the simplest case, I go there and sit down. Fortunately, I have the time now, so I go discuss. I learn one or two few things, one or two things that I may not. I'm not a radiologist, but I'm a practicing vascular surgeon, so radiology has an application. So that kind of interaction, teamwork has helped us. Otherwise, basically, my endovascular experience really is only about treating aneurysms, aneurysms or dissection of thoracic aorta, aneurysm of. So when aorta is ballooned and which is going to rupture in sooner than later, I'll be in the cath lab, and between the radiologist or cardiologist and me, we will do the introduction of the something like a parachute. It will open up, and rest of the vessels which are narrowed by cholesterol, which I mentioned, I don't actually do the intervention myself. It's done by either cardiologist and nowadays radiologist. So we work as a team, and we do the best way we can, each one of us. And that complementary, it's not like 5 plus 5 10. It is 5 into 5 25. So we magnify and glorify each other. Mistakes are less, and then we make sure that we discussed previous day. First time when we see the patient, then most of the times, there will be a delay of 1 or 2 weeks for maybe to put them on some medications, or maybe because they want some money, they want to arrange blood, they are not prepared to undergo admission, which is not required as well. So we see that and make a decision. Then the previous day we see all the investigations, and I myself ask for the investigation and look at each of them, and thank God, with God's grace, things are going well. Thank
Thank
you.
you so much for beautifully answering that. Like you said, five plus five is not 10; it's 5 into 5, 25, and that's how the whole medical team is working effortlessly. Continuously, day or night, neglecting other things in their life to be always there with the patient to improve their life, and in any way they can help the patients out, right? So thank you so much for being there for all the patients, for all the people who actually needed all the doctors at that point of time. Moving on to Dr. Ammu. Dr. Ammu, we already talked about the technical advancements in ENT sector and everything, but I would still like to know, what role do innovations like telemedicine or AI-based diagnostic tools play in improving diagnostics accuracy in ENT, and how can they be better utilized to safeguard patient health?
Okay, thank you, Simran, for that question. So, telemedicine, as we all know, post-COVID, telemedicine is one of the main thing into, hospitality area. So, what happens is with telemedicine available, we can keep a close follow-up of the patients. That is, if the patient is traveling from long distance, we can't ask them to come. If the patient needs a regular follow-up, we can't ask the patient to come every week. They're traveling from long distance. So in those patients, we ask them, okay, you give us a telemedicine consult, you do these investigation, you do this blood test, and then get back to us so that we'll know. So in that way, telemedicine is helpful. Second thing is if a patient needs a second opinion, and if that patient is in Gulf or somewhere and they want a second opinion, definitely they can put all their investigations, all their results, all the whatever the other doctors have seen, and whatever results they have, they can put it, they can forward it through telemedicine and then get an opinion from us. Or if we need, we can also tell them, see, you get this investigation done and come back. But whatever said and done, though telemedicine is very important and it is very helpful, seeing the patient person to person is entirely different. Let me just say that. But then again, if it is an old patient who cannot be shifted, who are financially poor, to shift one patient from bedridden patient from one place to another will cost a lot. So in such patients, the least they can do is do a telemedicine consult, ask us what they have or what all doubts they have, just a proper review. They can do all these things with the telemedicine. Also, in ENT, we've got something like voice therapy. Voice therapy is something we do for certain patients, like patients with vocal cord nodules and all. So for voice therapy, it is a continuous session of 5 days, 1 hour. Okay. So for this 5 days, you can't ask a patient to stay back. If the patient is from long distance, you can't ask, okay, come, you stay here for 5 days, for 1 hour, I'll give you a session. So in such cases, telemedicine is absolutely helpful because for that 1 hour, that slot they will receive. For that 1 hour, we can give a proper therapy for them. They'll also be comfortable at their place. They'll be very calm. They'll be telling us everything. They can even, show us whatever little difficulty they have. In that way, telemedicine is highly helpful. Coming to AI part, though earlier I said AI might substitute us, I don't know, but I strongly believe that manpower is very important. But still, AI pros are that in now recently for hearing aids and all, uh, for hearing aid and all, AI, based on AI, if we feed the audiogram to the AI, they will tell us what kind of a hearing aid we can give, like what kind of hearing aid we can, will be suitable for that particular patient. Similarly, all the hearing tests which are being done, all these hearing tests can be, taken up by AI, and they can give a most probable possible diagnosis, especially in small kids when we do BERA. BERA test is done for small kids with hearing loss. So for them, we cannot elicit a proper history from them. So all we depend on is BERA. And BERA is a very difficult result to read. Not everybody will be able to read a BERA result. It is mostly done by an audiologist, and even audiologists find it difficult to read. So when we have an AI set up with the tests of BERA being fed into it, it will generate a diagnosis, possible and probable. So in such difficult scenarios, when BERA is put in, when you put in a result, it will tell us, okay, this patient is having this thing. This is only for these particular cases. I feel AI will be useful at present. Maybe in the long run, when there is a possibility of putting a scope into the patient via a robot, then maybe AI will be coming into play in ENT much more, maybe more than 90%. But at present, I think the role of AI is very less because it has just started and data is just being fed into the AI. The more the data, the diagnosis will be more accurate. The lesser number of data, they'll only say probable, possible. So we need to put in a lot of data. And all the data which we put into AI should be absolutely correct. You should go through, you should make sure, okay, this is this, and then fed into it. Because otherwise, even the system will err. System will say, okay, you've done this earlier, so this is this. That error can also occur. So whatever you're feeding into the system, it should be done properly. Everything should be done stepwise. Everything should be done based on a protocol. And yes, AI will come into play in the long run.
Thank you so much, Dr. Ammu, for explaining that to us in such an elaborative way and explaining us the complete process, because that has helped us and the audience to understand how new advancements, telemedicine or AI-based diagnostic tools play in patients' diagnostic and safety. So that is very helpful for us. And you said it right. It needs to be fed by correct and accurate information, accurate data in a proper manner, so that whatever findings at the end of the day or time it concludes or give us, that should not be inaccurate. That should be proper according to the findings and the data fed to it. So thank you so much for this. And I would like to thank all the panelists for this panel discussion, for coming to this platform, sharing your insights and expertise with us, answering all our questions based on the different specialities you all hold. So it is really beneficial for us to understand the right diagnostics at right point of time from all the aspects of medical and clinical care. So thank you so much for this, and thank you so much for all the services our medical institution and the doctors like you are providing to our patients out there.
Thank you, Simran. Thank you very much.